Great. Hi everybody. I think we're probably about ready to get started. Hopefully everybody has got one of these apparently healthy donuts. I think that means everybody gets two. I'm just going to quickly get us started with a word about the Rising Stars program, which is part of the program that's part of the reason that brought Ednah to Seattle today. So Rising Stars is a collaboration between WACh, a population health initiative, and some individual grants within the Department of Global Health to give scholars from low middle income countries some seed funds, but also to extend the privileges of being, faculty and student and a trainee at the University of Washington to those individuals. So, we're able to extend library services, give some visiting scholar positions, and also bring a few people here to give talks about their work. And that program really aims to catalyze people's career at that stage where they're trying to become faculty and to create, our next generation of collaborators. And so we're really excited to have one of our inaugural Rising Stars here today. And I'm going to let Jen say a little bit more about Ednah, but I want to also say that we're doing another round of Rising Stars this year. So if you have collaborators, young investigators from low middle income countries who you think would be interested in this program, please watch out. I think we're going to be sending out some more resources about this next application cycle in the next 2 weeks. So please do share it. Really, it's open to anybody. All right. Thank you.
Yeah. All right. Good morning, colleagues in Seattle, and good evening, colleagues joining us from Kenya, especially Bethwell and Imani and baby Nathaniel, depending on whether success in getting him to bed. We are really happy to have you here today and I'm excited to introduce my friend and colleague, Ednah Ojee. I'm going to read off this first official part for you, and then I'll say a few words about Ednah. So WACh is pleased to host Dr. Ednah Ojee, recipient of the Center's 2022 Rising Star Award, for an engaging talk on her research career journey leading up to her funded projects, the association between health worker home visits and growth in neurodevelopment in children. This project is linked to the MTCV study, a prospective cohort study collaboration between University of Washington, Fred Hutch, and University of Nairobi. So as part of her talk today, Ednah is going to tell you all about her journey. So my job as an introducer is quite easy. I can just say nice things about Ednah. So I met Ednah in 2018 as a pediatrician and study coordinator on the Virome study. And getting to know her over these past, can't believe it's been 7 years already, I have just been astounded by Ednah's intellectual curiosity, her compassion, her excitement in taking leadership, and really just exploring everything to do with child health. You'll see from her talk today that she has been fearless in seeking out new knowledge and new tools to add to her professional toolbox as she embarks on her path to becoming an independent scientist. It's been a joy to work with you, and a lot of, seeing the people in here from so many different programs also speaks to just the many different stops you've made along your journey. And it's exciting to walk with you, and welcome. We're excited to hear your talk today.
Good morning, and thank you all for coming. That's one of my favorite quotes. Life is lived on the journey, not upon arrival at a destination. So I've learned over time that the journey is not very straightforward, and you'll see from mine that there are certain things that I wasn't thinking about, certain things I was thinking about. But as you go on the journey and not focus so much on one destination, then you so I find like the journey is the destination. So welcome. Karibu chai means welcome for tea. Kenyans drink tea all the time. So there's a teapot and a cup there, and I'm glad everyone has some tea. So I'll just briefly go through what my milestones have been over the last 5 to 6 years. So I graduated from my pediatric residency from the University of Nairobi in 2018. And that's when I joined Linda Kizazi as a study coordinator. Professor Dalton Wamalwa is the one who sought me out. I'd actually been hoping that he could be my mentor in research, but he's very busy. So it was very special that he sought me out and I didn't have to wait in line with many people. And then my interest in home visits, and I started thinking about exploring this to improve newborn outcomes. Because when he told me about Linda Kizazi, my first thought was the home visits for the newborns. So I was very curious about that because, and I'll explain a little around why my interest in newborns and their survival, because we've seen a lot of mortality due to preventable things. At least during my residency, I saw a lot of that. So when I was thinking about doing some work in the home visits, the thought was either to submit it as a modification of the Linda Kizazi protocol, but I think one of the PIs on the Linda Kizazi study, Dr. John Kinuthia, who's also involved with ethics, told me, I think you should write it as a separate proposal. And that was very instrumental for me because you'll see later on, in writing that as a separate proposal, I was able to use that work for my PhD now. So as in the process, and here in the blue, just means that in the research journey, there's usually a point where you're kind of in the water and you're not sure whether you're floating or drowning, when you're trying to write, and then you're submitting to ethics, and then they're sending you comments, and then you have to submit to ethics in Kenya, IRB in Seattle. So the blue is just, you're in the waves and in the ocean, but it's okay. The floating will come. And then, so after the submission to the ERC and approval, the approvals from ERC and the IRB here, I then, because I had a proposal, I applied for the CIFA Pilot Award, which I got, and I'll talk about that a little. And then in 2020, the red is where challenges come. COVID happened. So the way, and I'll explain how the study was designed, we could not continue with the study the way we were doing it initially. And so we had to close the study temporarily and then kind of modify how we were doing the study and doing the home visits, and then reopen the study. So at around the same time in 2021, at the time I was working as a tutorial fellow in faculty. And there was a requirement for faculty to have a PhD requirement to teach. So my initial plan was to do a fellowship in neonatology, but then this requirement came. So initially I wasn't very keen, but Dalton kept saying, you need to use your work for PhD. You have enough work, and the things that you're thinking about is PhD work, so you need to think about it. And I think that speaks to mentorship. And he told me that you should have Jen as your mentor from Seattle. And then he recommended Prof. Were and Dr. Luvala as my mentors from the University of Nairobi. So again, I appreciate the role of a mentor who knows how to match you with the right people to be able to then progress you to the next place. Then, so basically what I did for my PhD work is I leveraged what I was already doing for the CIFA Pilot Award, but I expanded it. And then I included a component on COVID-19 because our studies were modified to include telehealth. So for my PhD work, I included that. And then of course, at this point, you have to then go back to ethics and tell them that I want to use this for PhD again, because I couldn't use it as it was. So I was very fortunate that ethics allowed me to then use my work for PhD and modify it slightly. The process of full registration for PhD at the University of Nairobi is very long and drawn out. It took me about 2 years to get my full registration. So again, I kind of found myself in the waters. But I got my full registration in 2022. And then I'll tell you just a little about where I am at with my PhD work now. So I want to just introduce part of the Linda Kizazi team, and a few of them are here. I see Grace John is here. Thank you for coming. So there's Professor Dalton Wamalwa. He's my senior faculty at the University of Nairobi. We have Dr. John Kinuthia. He works with Kenyatta. He's in charge of research at Kenyatta Hospital. There's Dara Liman, she's here as well. There's Ephraim Lim, there's Jens like Soren Gant is in Canada. Grace John Stewart, Emily Bavner, and myself. And this is out of the very initial training that we did for Linda Kizazi just before the study actually took off. So this is just a little background to the Linda Kizazi study. So Linda Kizazi is Swahili for Protect the Next Generation. It's a prospective mother-baby cohort that's designed to understand transmission of viruses. And there was an emphasis on cytomegalovirus, which is the component in which we did the weekly home visits. So we followed these mothers, and they were both mothers who are HIV negative and HIV positive. We recruited them in their 3rd trimester and followed them to delivery as they were newborns and up to 24 months. And then basically in terms of data collection, we did this at the clinic visits as well as at the home visits. So the clinic visits would follow the usual schedule for the mother-child clinic, where the babies come for immunization at 6 weeks, at 10 weeks, at 14 weeks. And then they come for vitamin A at 6 months. And then at 9 months, they have their measles, mumps, rubella vaccine. And then at 12 months and on to 24 months. So for that component, there are some mothers who self-selected to go through the clinic visits, but there was a smaller subset of 100 women who, in addition to receiving these clinic visits, received weekly home visits. And these home visits were conducted by a pair of a nurse and a peer counselor. So they would go and, in addition to collecting data and the biological specimens, there would be a wellness check for the mother and the baby. And the peer counselors would offer support for the HIV positive women around adherence to ART, prevention of mother-to-child illness. And then the nurses would then offer support. If the mom was unwell, teach her about danger signs, support breastfeeding and lactation, support complementary feeding. And so these mothers would be visited every week for 52 weeks. And so there's a critical period, the first 28 days, when we see a lot of babies get acute kidney injury and sepsis because of lactation failure. So that's a critical time point for these home visits because we can catch them early. And when these children get sick, they would end up in Kenyatta, admitted to the renal unit for dialysis or to the NICU because they are very sick. And that can be prevented if we Okay, I've lost my screen, but I think I have some days. It's okay.
I went to sleep.
Okay, so that's basically about the Linda Kizazi cohort. So I'll just speak about some of the work that some of the research findings we've been able to get. This is from a paper we published in PLOS One. Emily Bavner and I were first joint co-authors for this. And the paper was, we were analyzing HIV and SARS-CoV-2 infection among postpartum Kenyan women and their infants. So our first aim was to describe the incidence of SARS-CoV-2 infection among postpartum Kenyan women and their infants. Second one was to assess maternal and infant correlates for SARS-CoV-2, including maternal HIV status. And then secondarily, we wanted to look at the relationship between seropositivity and reported symptoms and to describe shedding in stool. So the analysis was defined as having at least one positive serology test. And this was done at the University of Nairobi Paediatrics Research Lab. So in terms of incidence, time at risk was defined as the number of person days between 1st of May 2020. And if seropositive, the estimated date of infection, and if seronegative, the last date of the negative test. And then we also looked at the correlates for SARS-CoV-2 infection. So in terms of the characteristics of what we were able to analyze, we tested 126 mothers for antibodies. Their median age was 28 years, and 64 of them were living with HIV. And for the women who we recruited, they had been on ART for a median of 5 years. So virally suppressed, well-controlled HIV. And then we tested 125 infants. Median age was 6 months, and 64 of them were exposed and uninfected. So there were no cases of severe COVID-19 or deaths due to COVID-19 in our cohort, which is good. So we detected 83 cases, that is 66%, among the mothers and 55 among the infants. And we did not find significant difference by HIV status or exposure. I think we can allude to that because the mothers were virally suppressed, and so their immunity was good. So in terms of thinking about the correlates, so for the mothers, their age at the time when we did the analysis, the hazard ratio was 1.06 with a p-value of 0.06, so there was some relation there. And then in terms of crowding in the house or in the room, we found that significant, and then the number of prior live births. So looking at the symptoms of COVID-19, if they were seropositive, and the symptoms we defined were fever, chills, cough, shortness of breath. So in the weekly visits and in the clinic visits, we would ask about symptoms of viral illness every week. So it was very good for us because we had a very rich data set already. So because COVID presentation was similar to how some of the viral illnesses present, all of these we were able to see, looking back at the data, if any of these symptoms had been displayed by the moms. So only 1/3 of the infants and less than 1/5 of mothers reported any symptoms. So basically in this cohort, they were asymptomatic, majority of them. For the infants, symptoms were almost 3 times more likely at first seropositive visits than visits before the infection. So our conclusions were the risk of SARS-CoV-2 infection was high among these postpartum Kenyan women between January and December of 2020. We did not find that women living with HIV had a higher risk of SARS-CoV-2 infection compared to HIV negative women, and this speaks to supporting women to ensure viral suppression, because then you would have similar outcomes between those HIV positive and those who are not. And then for the infants whose mothers had SARS-CoV-2 infection, who had COVID, they were substantially at higher risk. And this possibly gives us a suggestion that there could have been vertical transmission, but we couldn't quite determine the direction of infection. Majority of the infections among both the women and the infants were symptomatic, and this was reported similarly by the Ministry of Health. So these are just some of the publications that have come out of the initial work of Linda Kizazi. So there was the article that I've just shared some findings from in +1. And then there's another one that came out in the Journal of Medical Virology. And then this one by Caitlin as well in viruses. So that's just some background to Linda Kizazi. And then I'll just, from here on, I'll share how my work was nested or linked to the Linda Kizazi work. So I had mentioned the CIFA Pilot Award. So just briefly, the purpose is for development and implementation of innovative and collaborative HIV-related research projects in developing countries by junior faculty. So when I applied for the award, I was looking at the home visits specifically for women with HIV. But then now when I came to my PhD work, I'm focusing on all the women. So the award was tailored more towards women with HIV. And basically the study is supposed to give me, I'm supposed to use pilot data to develop future grant proposals. So my motivation for looking at home visits for improving survival for newborns, despite significant efforts, neonatal mortality is still a burden in Kenya, and we need new strategies to be able to avert rising cases. So you can see the neonatal mortality rate has sort of remained constant, although we are coming down now, but it's kind of plateaued around 20 between 2014 and 2019, when we are making significant strides with under 5 mortality rate. But the neonatal mortality rate is a big driver of the under 5 mortality rate there. So currently we are at 21 neonatal deaths per 1,000 live births, which is still high. And for this reason, neonatal mortality is still a burden in Kenya. And like I said, new strategies are needed. So these are some of the strides that have reduced neonatal mortality and morbidity. So we implemented the 4 antenatal visits initially, but current guidance is 8 antenatal visits. So we moved from 4 to 8, and then we have very robust neonatal guidelines. And the ETAT work, which I coordinate, contributes a lot to reviewing those guidelines and improving them based on evidence-based medicine. And then infection prevention, care of the cord with chlorhexidine, and the introduction of kangaroo mother care for neonatal thermoregulation. So I think I've spoken a little about that. So before COVID, my interest in the home visits as a low-cost intervention for newborn survival. So like I said, it was an opportunity to explore what was not designed as an intervention, but to see how this impacted outcomes in this cohort. So the home visits were self-selected. The moms chose to receive extra home visits or not. So it wasn't like they were randomized or they were kind of allocated to one or the other. This was self-selection, and of course that would introduce bias. So it was not an RCT or intervention study. As much as they were designed for data and specimen collection, the additional benefit is what I'm looking at. And so this a pilot study to inform the design of health worker home visits as a low-cost intervention to reduce morbidity and mortality among HIV-exposed Kenyan neonates. So those were the CIFA pilot award aims, but I'll speak about them later for my PhD work because this was very tailored to the women living with HIV in the cohort. So how my home visit study came in, the additional home visit follow-ups were conducted for women who elected this group. So because this is a well-designed and supported cohort, this has provided me an opportunity to nest the first objective of my PhD work with an aim to understand whether there's a benefit to providing postnatal home visits in a research study setting, and then further explore the benefits to women living with HIV as part of the package. So last week, part of the reason I came is I attended the implementation science course last week. It was very intense. We were in class from 8 to 5 every day. So it was interesting because as I went through the classes, I kind of felt like maybe my work has something in implementation science. And so I'm very excited to think about scaling it up because I think last week made me really think that what I'm doing now can actually be scaled up as a strategy and something that can be taken up by the ministry as we roll out universal healthcare. So home visits are an evidence-based intervention that has been demonstrated as effective by the WHO and UNICEF for improving newborn outcomes. So I'm also doing some qualitative work, and this stakeholder engagement for the design or delivery of a strategy for sustainment and scale-up is what implementation science is about. And then I'm looking at the cost of providing this intervention within the study setting, but I'll also compare other models where if this was to be done by the government, maybe employing a government nurse or using community health workers who would then be taken up to provide this. So for that, just comparing alternative models to deliver this. And then during COVID, we changed, instead of going to the mothers into the homes, we were doing remote visits. So they would go and collect the specimens, but they would be somewhere slightly out of the home. But another component was telemedicine, where the nurses would call and the peers would call the mothers, find out how they are, remind them about whether it was things related with vaccines or just do the wellness check. And so this is something that I was also looking at how this can be used in situations like in pandemics to continue to connect families to healthcare, especially when like a mom has a newborn and can't come into hospital like during COVID, if she can be able to still be linked to a healthcare system where in case of anything that she can get support. So my first aim, this is just during COVID, I had a lot of opportunity for online learning. That's something, so COVID was not such a problem. I think there was a blessing in COVID because I got to learn very many things during that time. And I was even able to join Christine for the fall quarter in the qualitative methods course. So I didn't have to come to Seattle, I was able to learn from home. So for the first aim, I was able to join my colleagues online for a semester in statistics and epidemiology. And then I joined the CIFA Behavioral Science Core for qualitative research methods. And then we did a quarter with Christine during that time. And then I was also able to do the 10-week course online, Economic Evaluation in Global Health. And then I joined one of Carol Levin's sessions for the HACE session. So these have been very instrumental in terms of me thinking about the design of my PhD and how I wanted it to look like. Yes, so COVID-19, new research and learning. So basically what I did is to leverage the changes that were made to our study during COVID-19 to explore alternative models for linkage to healthcare systems during pandemics. And so that is how I ended up with what I'm doing for my PhD. So I'm looking at the health outcomes and cost of postnatal home visits on mothers and infants in the Ednah Ojee study before and during COVID-19. It should actually be before and after, I think. So UNICEF and WHO have a joint statement. There's a lot of evidence that they have that says that home visits for the newborn child are a strategy to improve child survival. So this is like the backbone of my work to say that these home visits actually make a difference. So for my aims for my PhD, so I'm comparing infant and maternal outcomes between the mother-infant pairs that receive weekly postnatal home visits in addition to postnatal clinic visits. To those who receive the clinic visits only. But there's a sub-stratification where I'm looking at the women with HIV and comparing those as well. So the first aim is nested within the Linda Kizazi work, and it's a secondary analysis of data that has already been collected. So for collecting new data is my second and third objective. So for this, I'm using mixed methods. So I did an exit survey with all the moms who were in the study, both those who received clinic visits and home visits, to understand their perspective on home visits. But then I also am doing, this one is majorly qualitative. So interviews, in-depth interviews with the mothers and in-depth interviews with healthcare workers on their experience of the home visits, to understand the barriers and facilitators, and to understand what they would feel would be the components that would go into the design of an ideal home visits package for them. And then for the healthcare workers to understand how they felt delivering these visits, the barriers and facilitators, and as well from them what they think would be the ideal components. And then based on those based on those findings and the cost that I'll find in the third aim, I'll speak to health administrators and policymakers and tell them, this is what we found about these home visits, this is what moms would want, this is what the health workers say, this is what we found the cost would be in a research setting and alternative costs, and find out from them, is this something you would want to put money in? And of course, I'll compare it against the cost of a child who comes into hospital very sick, gets admitted to NICU, to the renal unit, all that cost compared to doing these home visits. And if there's a reduction in cost and we can save more children, I hope that this can be scaled up. So where I am at currently, the secondary analysis for my aim one is I'm currently doing that. For the qualitative work, the exit surveys have the mixed methods. The exit surveys and preliminary analysis has been completed. For qualitative data with the mothers and with the health workers, that's complete. We are currently finalizing coding in preparation for analysis, and Christine has been very instrumental in this. Thank you, Christine. And then for AIM3, we finished collecting the cost data, and we have preliminary costs for the home visits. So currently we are trying to work on alternative models. How much would it cost if we're providing the service by a government nurse, and how much would it cost if it was a community health worker? Community health workers are not employed by the Ministry of Health currently. So this would be a place where probably they would consider using community health workers, because of course they are short-staffed, and sending a nurse from a health center to visit moms and close the health center wouldn't make sense. So my interviews with the policymakers will be conducted after completion of the preliminary analysis from the mother and health worker interviews, and the costing has been completed. Yes, and to the third part of my presentation, and how I came into the Rising Star work. So when the first phase of Linda Kizazi was ending, we got PO1 grant to study neurodevelopmental outcomes. So basically an extension of the Linda Kizazi cohort. Remember I said we were following them children up until 24 months, which is 2 years, but we got extension to follow them up until 4 years. So our goal was to re-enroll 125 participants, and then at 3 and 4 years of age, they would get neurodevelopmental testing using the executive function touch. And it's a tablet-based tool which has been validated in Kenyan children. And those are some of the subdomains that we'll be evaluating. And then at 4 years, they would receive the Kaufman assessment battery for children. And those are some of the domains we'll be evaluating. So this has been a busy year. At the beginning of this year, we did towards end of last year, I received training together with the team in administration of ETAT, and our study clinicians are doing that. And then Linda Kizazi employed 2 psychologists, Rachel and Hemston, and they are administering the KMPC. So Kank has talked about the Rising Star Award, and I'm very thankful for the non-residential visiting scientist position that I have here, because it has given me a lot of opportunities for learning to analyze data. I'm learning R on my phone. There's a phone-based app. It's very cool. There are very many games to play as you discover about R analysis. Thanks, Kank. So for the Rising Star Award, again, I'm leveraging the PO1 for the MIND Project 3 to look at the association between health worker home visits and growth and neurodevelopment in Kenyan children. So I just want to say thank you to the Rising Star mentors for their mentorship. I've had the opportunity to collaborate with other awardees, and it's an opportunity for peer learning. And like I said, I'm learning to analyze data using R in a fun way. And then thank you, Irene. I'm now reflecting on my individual development plan, and it looks like I might be in the waters again, but let's finish the PhD first. So for my aims for the Rising Star, I want to determine the correlates of optimal growth in Kenyan children during the past 4 years of life, and then compare the 3rd and 4th year neurodevelopmental scores between children who receive home visits and those who receive clinic visits. That's my approach for analysis. And then I'll just share a few highlights from some of the things that gave me the foundation or the interest in research, and some of the people that are here. So Caitlin is here. We went with her to Kisii during residency. And during that time, we looked at adolescent sexual reproductive health, which both of us are not interested in, but it was a good opportunity to get research skills. So this is, so we had when we were in Kisii, we cooked for the staff who used to cook for us there. So Caitlin made pizza and I baked a cake. So that was fun. And then this is Jemima. She was the first cohort of the REACH program. I think she came with Douglas. So I think this is when we went to see the elephant. Yeah, we went to the elephant farm. And then this is during my residency in Migori. I think that's how I met Kirk. So I was looking at gestational assessment of late preterms towards improving their survival when they go home, because our late preterms are usually missed, and they're the ones who commonly come back with acute kidney injury and failure because they're not able to breastfeed well, their immunity is not very good, but because their weight is kind of on the borderline for going home, if you don't assess them, they'll go home. So they set up the kangaroo mother care ward while I was doing this work there. And this was a collaboration between KEMRI and the University of California in San Francisco, the Preterm Birth Initiative, which was also a cohort. So again, I nested my study within that work. So there's always opportunity. When there's cohorts of work that's going on for a long time, there's always opportunity to explore new directions. And then this is in Kisumu. I think this is where I was sharing part of my results from my residence research. And then this is the last time I was in Seattle. This is from Chikuli in 2017. And Banis is the one we came with. Yes, and yeah, so I want to say thank you. So I want to thank the University of Nairobi for the opportunity to be here, and just for the opportunity for the collaboration between UW and University of Nairobi, my mentors. There are many. So Professor Dalton Mamalwa, Professor Ruth Duati, Professor Obimbo, and then my PhD supervisors, Prof. Were and Anubala. The CHEP Reach team. Reach, I was telling them yesterday that all the things I wrote when I came here have come to pass. So it was a very good time in my career to think about where I wanted to go. Linda Kizazi team, I think all this would not have happened if I didn't come into Linda Kizazi. So it just provided me an opportunity to really grow. And then to the CIFA team for giving me the award and the opportunity to just explore my research interests, because research in residency is not liked. So I feel like my path is very different, because residents usually just want to finish and go, and they find research is an extra task. But I think if you do meaningful research, or if you find where your passion is, because you see, for me, my passion is in newborn and newborn survival. And fortunately for me, Linda Kizazi was doing something in that direction. And so if you know what your path is, you can be able to kind of chart your own path, because I feel like mine was not a very direct path, but it's possible to use research to actually make a difference. And then, of course, the Rising Star Committee, and for all the opportunities I've had to be able to grow and to learn, and of course, to Global WACh for hosting this breakfast. So, asante, that's thank you in Swahili. Then discussion, questions.
That was fantastic. I'm Carrie Barker. We'll have to meet after. I work very closely with Ruth and Dalton.
Yes.
So I have two questions. One is that you showed that WHO UNICEF document on home visits, and yet it doesn't appear that they're happening in Kenya. Are they happening in other parts of the world, and are there sort of outcomes and lessons learned from that? Because it usually when there's a document like that, often Kenya is one of the first to kind of pick up. That's
Yeah, so
I'll ask my second question after. That's good.
So I think Burundi has a very robust strategy. Rwanda. Rwanda has a very robust home visit strategy in Ethiopia. In Kenya, they're not happening as a directive from the Ministry of Health, but there are certain community-based organizations that are doing, like in Siaya district, there are some projects which are being done, but we haven't embraced it as a national policy. I think last year in November is when the guidelines for care of the small baby came out, that then endorsed that these home visits now should actually be incorporated as part of the care of newborns, but we haven't taken it up yet. So I'm hoping that this can influence policy.
My second question, which shouldn't come as a big surprise to Grace at least, is when you're at home visiting these mothers and you're building that trust, is there any discussion around the partners and engaging the partners, testing partners for HIV for those?
So that's a good question. So, and that's one of the barriers to home visits also. So for the moms who selected the home visits, they knew that they would not have a challenge. Most of the moms, they knew that that would not be a challenge. But a few of the moms, because especially the ones who hadn't disclosed their HIV status, would want to receive the visits, but in the absence of the partner. So we would call them before to arrange the visits. And if they say, no, don't come today, then you know that probably there's non-disclosure. But then for the other moms, most of them, and I remember from some of the qualitative interviews I've looked at, the partners were supportive and the partners said, yes, you can be involved in the study. So we haven't actively involved them, but for majority of the ones who selected the home visits, they had their partners.
Curious if you, in the outcomes for the babies and the mothers, if you looked at maternal depression, postnatal depression.
That's a very good question. I haven't, but I know that that is something that is important. Although in the exit survey with the moms, as well as in the interviews, we actually ask them about maternal depression. I just haven't looked at the data keenly, but we have a section where we ask about, especially during COVID, did you feel supported by the study? Did you feel the health workers were supportive of you, both in the in-depth interviews with the moms and also in the exit survey? So I haven't looked at that section, but yes, we've asked about it.
Yeah, it'd be particularly interesting with the is it MIND study? I don't know.
Yes.
Yeah, it's neurodevelopment.
Ednah, that was fantastic. I really like the team in that slide. But I like the way that you wrote the story of how you took opportunities and nested them in the research. And I had a couple of comments and a question. One was, you know, obviously you alluded to the selection bias issue where these are very motivated. Like, for instance, some mothers with HIV are treated, virally suppressed, so they don't represent most ones with HIV. Similar with research, maybe the data specimen collection is slightly different than a conventional home visit. So you're trying to kind of extrapolate cost and qualitative issues to the real world from the research. So I was curious, just some comments on that, but then also whether the other thing you alluded to was televisits and whether you've had a chance, because Dr. Kenyan works with Dr. Keshet Ronan, who does CHV Neo, which is looking at neonatal health with telephone visits with the new study coming on board. Just visiting with her and getting those ideas might be helpful. So just your thoughts on that extrapolation from research to real world, and what I'm really wondering about, given how successful you've been at leveraging, is how you see yourself going forward after this. Like, what's your next big
So that's a good one. So we actually had, so we wanted to actually do some work as an RCT for home visits, and we submitted a grant, but we were not successful. But we're still pushing on. So we hope to do this now as an RCT because, of course, there's limitations to the way I'm studying it and the way I'm looking at it. So, and we want to be able to, and you see, if we design it that way as an RCT, in terms of even determining the cost, we'll be able to get the incremental cost effectiveness ratio. So that will be real world and real time, and it will give you more robust results to be able to build a case. So we are still working on it. Thank you. Yes,
Thanks for the really nice talk. I wanted to ask, because the newborn visits are now in the guidelines. And I know that recently the president kind of set up this health agenda that includes community health workers as part of the package. Okay, I know it's not started, but it's probably in the pipeline. So I know the community health workers will probably have so many other things to do other than just newborn, but I think it might be the time to actually really advocate for newborn to be a key component of that package when it comes out. So any linkages you have with the Ministry of Health or people working there who can kind of push the agenda. I know pediatricians are really good at that.
So that's a good question, Irene. It's interesting because so the hospital where I teach, Magathi Hospital, I serve on the board. And we are currently trying to see if we can, there's the primary health, they call it primary health network, which is how the government is rolling out the UHC. So they want to try and kind of implement it at that facility and then see how it will go. And so that facility is one of the places, they say it's a hub and spoke kind of model, where they're trying to see how they can be able to engage the community health workers. But the thing with the community health workers and these visits is to decide the critical time points when these moms need the most support, because of course you can't do weekly visits for 1 year. These moms work, they have other things they do. But we know in the first 28 days, at least within the 48 to 72 hours after the baby is born, 7 days, 14 days, 28 days, that's a critical time period. Then we know at 6, 10, and 14 weeks, they're in contact with the healthcare system. So that's a critical period. Then maybe you could say between 3 and 6 months, maybe put 2 visits, and then at the time of complementary feeding. So you could kind of structure it in a way that in between those long periods of lack of contact, but finding the ones that are most critical. And I think the first 28 days are very critical because we lose many of these babies within the first 7 to 14 days. Yeah. Yes.
Hey, they're really a wonderful talk, and then yeah, just amazing to see how you brought together people and resources at UON and UW to create this trajectory. It's really speaks to how collaborative you are. It's amazing.
Thank you.
I wanted to ask, you know, in your experience, having worked in Nairobi and Migori, and I'm sure you've traveled and worked in other places in Kenya as well. When you think about this community work in the devolved healthcare system, do you see there are big differences in attitude and resources available in different counties across Kenya, or do you think that there's some sort of standardized platform for this work to roll out across?
So I think Kenya devolved healthcare after the last election, and that's been a big problem because it's kind of like, so the people who had the so we had the administrative units are called counties, and it's headed by a governor, and then he has like the people who he leads the county with, and they are the ones who determine how they will spend the county budget and the money. Previously, healthcare was centralized, the Ministry of Health, and so the budget would be distributed based on the need of a region, because some places are more populated, others are less populated. So that was a better way. It was a better fit to do it. But the way it is currently, we would probably need to, after pilot work, go to county by county. And so they usually have the Minister of Health in each county, and then be able to talk to the to the Minister of Health for each county, and then tailor it to each county based on what their budget is. So it's not a good way to do it. It's better, I feel health should be centralized, and then the budget should then be distributed based on the need of the counties.
Can you teach us about the magic of the home visit? What happens in this interaction? That's so magical, right? It doesn't seem to work if the woman comes to the health center. It doesn't, would it work if we had group visits with a bunch of new moms? What's the magic?
So from the interviews that I've looked at, the first thing is the moms feel it saves them the cost of coming to hospital. That's the first thing. And then it saves them time because they know that every week a health worker will come. But also when the health workers come, they give health education to these moms on danger signs. So these moms are very alert. If something goes wrong with the baby, they're able to pick it very quickly. Because usually you find that with first-time moms who are nursing for the first time, they're not able to tell that if my baby doesn't change 6 to 8 diapers in a day, that's dehydration. But for these moms, they know. So if that happens, they come to the hospital immediately, or they'll call because they have the numbers for the nurses and the peer counselors. That's one. The second thing the moms say is that they feel more confident in taking care of their babies. But then health-seeking behavior is greatly improved, because usually what would happen is they get advice from other moms. The baby is crying, give them water, give them prelactual feeds, and those are some of the things that then, and sometimes they give them herbs, and those are some of the things that lead to the complications. So as the health workers go, from the interviews I've seen, the moms are saying that I've learned so much. I even talk to other moms if I see a problem with their child. If the health worker is coming to visit me, I tell them to look at this child. My neighbor was helped. So it's kind of like a ripple effect. And now they're talking amongst themselves. So they were saying, one of the moms said she wants the visits to go until 5 years. Yeah, but she said even if my child needs to go to school, I'll keep them at home for the help. So that's not very good. You want them to go to school and to go to hospital, but well, it's not such a bad problem. I think the other thing is also for the moms themselves, because they're so occupied with taking care of the baby, they forget to sense danger signs themselves. So if they're having symptoms of anemia, if they're having puerperal sepsis or anything like that, then also they're able to pick up their danger signs early, including even because sometimes they get preeclampsia after delivery, so they're able to then go to hospital.
I wonder about maybe in a more densely populated area, maybe not so dense as like Nairobi, but somewhat dense, where if you did group practices, group visits, would that be more efficient and cost effective and for the health worker? But still, of course, most importantly, have the same success for the babies and moms, you know?
And I agree with you, and maybe group visits, shared experiences
they
would
should
also like encourage, because we do that a lot with the preterm moms in the hospital. So the ones who've stayed longer will kind of buddy with the ones who are just coming in, especially with the preterm, with extreme preterms, and then they kind of buddy and walk with them along until discharge. So I think that would be worth exploring.
Especially in a place where there may not be enough health workers, you know, there's, you can leverage some.
That's what I'm exploring. Thank you. Yay. All right.
We wrap, shall I wrap it or you want to wrap it? We'll wrap it. Let's wrap it.
Thank you so much for joining us this morning. This was great. Perhaps Dr. Ojee will be around for a few minutes if others want to chat. As you've heard, she's very collaborative. So want to talk to her and maybe some research magic can happen. Thank you for joining us and have a great day.
I discovered the collaborative side of me through the REACH program.
There you go.
There's a strength finder called the Gallup Strength Finder. I didn't know that's what it's called. It's called connectedness. Yeah, thank you so much.